Thanks for having me. It's really an honor to be here and humbling to be sharing the podium today with such great young researchers. As you alluded to, I've got some NIH funding and funding through the Doris Duke Foundation, and also have received some honoraria for advisory board work from ARJO. Otherwise, nothing pertinent to this presentation, though. So I don't come from Toronto or London, cities you may have heard of. I come from Nashville, which is some of you have been to, but it's here in the southeastern United States, and it's famous for being Music City, USA. And these are the honky tonks that are pretty popular on Friday and Saturday nights. Great live country music, cold beer, good barbecue, that sort of thing. But Nashville is known as Music City, but it's also a big healthcare city. Healthcare is actually one of the largest employers in Nashville. There's a couple of large national healthcare systems that have their headquarters there in Nashville. And to curry favor with the Australian audience, we also have some famous Aussies that do live in Nashville with Nicole Kidman and Keith Urban here, proudly displaying their Nashville Predators hockey sweaters. You didn't know that they were hockey fans, and neither was the rest of Nashville until the Stanley Cup finals last June. So we're all quite proud of our hockey team. But I think some of the more important people that live in Nashville are these folks. And this is the research team that I work with on a day in and day out basis. This is the Vanderbilt ICU Delirium and Cognitive Impairment Study Group, headed by this gentleman here, Wes Ely and Pratik Pandrapandi. It's a really great interdisciplinary group. We've got doctors and nurses, intensivists, ER physicians, psychologists, psychiatrists, pharmacists. I'm just looking at geriatricians, epidemiologists, biostatisticians. So it's a large group, and everything I share with you today is a group effort. So by no means am I special, but I'm one member of this group. It's also nice to be here in Australia presenting because of these studies like this that have come out of the ANZICS group here. And these are data from the core database here in Australia that show, or Australia and New Zealand, that show improvements in mortality for patients who suffer critical illness. And in fact, if we look from 2000 to 2012, the risk of dying from critical illness is about half of what it was. And we oftentimes pat ourselves on the back. We're doing such a great job of saving lives in the ICU, and then that is a good thing. But there's a concurrent trend presented in this paper as well, that those patients are surviving, but they're not returning home. Here, instead of looking at the odds of mortality, we're looking at the odds of being discharged to a rehabilitation facility or to a nursing home. And the reason people go there is that they lose the ability to function independently. They become disabled after their critical illness. And what you can see is that, analogous with that trend of decreased mortality, that the odds of being discharged to one of those facilities has nearly tripled during that time. So people are surviving, but they're not returning back to the way they were before. They're developing new disabilities that require at least short-term rehabilitation and sometimes longer-term stays in nursing homes. So what I want to talk with you today over the next 20 minutes or so are three topics. The first is to talk about how we understand disability, how it may develop during critical illness using a thing called the vulnerability hypothesis. And then we'll talk a little bit about clinical factors that are associated with increased vulnerability that are associated with the development of disabilities after critical illness. And then we'll talk about some early mechanistic work looking at the role of acute inflammation during critical illness and its association with delirium, which is a syndrome of increased vulnerability, and then disability after critical illness. So before we go too far, I do want to spend some time talking about terminology. We're all new to this field, right? To the survivorship issues, and so we kind of throw around terms, and oftentimes I, even when I started in this, would misuse them and confuse them. So let's spend a few minutes talking about the disability process. And there are a number of clinical models to describe the disability process, but one of the most easy to understand and actually helpful conceptually was written by Verbrugge and Jett back in the mid-90s, and we modified it and updated it a little bit for the ICU in a paper in CCM back in 2015. And what the disability process in this model states is that pathology leads to impairments, that leads to functional limitations, that leads to disability. So let's dive a little deeper into those terms so we have a good understanding of them. Pathology are diseases or injury that disrupt normal physiologic function or homeostasis. We're very familiar with that in the ICU. Those are things that we see in the ICU. Likewise, impairments are also very common in the ICU. That's dysfunction and structural abnormalities in body systems. People come to us because they have respiratory failure, because they have shock. We can think of those as impairments. And more recently, we've started to be concerned about muscle impairments and brain impairments. Functional limitations, then, are the result of those impairments. They're restrictions in basic physical or mental actions. And then when those functional limitations are placed into a specific context, we have disability, in which is the inability to perform socially defined roles and tasks. So let's look at this in the context of critical illness. Again, with our pathology, impairments, limitations, and disability construct, we have a patient with sepsis and ARDS. And we know those syndromes are associated with muscle wasting and changes to muscle composition. We also know that they're associated with delirium and cortical brain atrophy. We take that muscle wasting and the changes to the composition, it impairs muscle function. Muscle weakness, balance, and fatigue are the result. With delirium and cortical atrophy, we have some longer-term cognitive problems, thinking and memory problems as well. And so those may not be a big deal when a patient is in the hospital and there's lots of people around to help them do things. But once they start to transition home, that's where we focus on disabilities, things like activities of daily living. Society expects you to be able to put on your clothes, to be able to eat by yourself, to be able to bathe, and to be able to handle, on a similar level, your finances, your instrumental activities of daily living. Finances, being able to cook, being able to move around your house, your neighborhood, that sort of thing. And for our younger survivors to be able to maintain gainful employment. So the difference between limitations and disability, again, has to do with the social context. So let's talk now about how do disabilities develop, or how do patients end up in this, with these problems after they come through the ICU. And the vulnerability hypothesis is borrowed from one of my mentors, Tom Gill, who is a geriatrician. And the geriatricians are years ahead of us in terms of studying these problems because they've been studying them in the context of aging. And we're studying them now in the context of critical illness. So the vulnerability hypothesis of disability basically states that disability develops as a function of a patient's critical illness and their underlying vulnerability. So if we have a young patient who's really robust, no other comorbid conditions, and they develop a urinary tract infection and some septic shock for a few hours, they get turned around pretty quickly, they have pretty low vulnerability and a pretty low intensity critical illness, that patient won't go on to develop disability. But now let's say that same young, robust person comes in with severe ARDS and multiple organ failures that go on for a prolonged period of time. All of a sudden, the intensity of their critical illness goes way up, and regardless of their underlying vulnerability, that patient will go on to develop disability. And likewise, the analogous thing of that low-intensity critical illness, if your vulnerability is high enough, if you're a person of advanced age with multiple comorbidities, for example, you are likely to develop disability as the result of your illness. And so the intensity of critical illness, I think, is pretty intuitive to us. It's what we spend our days measuring: SOFA scores, Apache scores. We worry about how long people are on the ventilator, how long they've had renal failure, those sorts of things. So the intensity part's pretty clear to us. What's less clear is how do we measure vulnerability? And there's no good clinical scale to measure vulnerability. Except there are a couple of syndromes that are increasingly recognized in the ICU and in patients with critical illness that can help us to understand a patient's vulnerability. And the two that I'm going to talk about today are delirium and frailty. So we'll talk now about those two factors that are associated with increased vulnerability. And the first study that I'm going to present to you, we published in Critical Care Medicine, looking at the duration of delirium and its association with long-term disability in survivors of mechanical ventilation. And we did this study in the context of the Awake and Breathing Controlled Trial, or the ABC study, which was published in The Lancet back in 2008 now, I believe, getting up there. But anyway, and that was the RCT of a spontaneous awakening trial, turning off a patient's drug, and combining that with a spontaneous breathing trial, doing pressure support spontaneous breathing trial, that showed improvements in a number of ventilator-free days, as well as improved one-year survival. And so we then followed those patients out and assessed not only mortality, but also their disability status. We measured delirium in the ICU using the confusion assessment method for the ICU. And this is probably familiar to you, but it measures four features of delirium. And for delirium to be present, feature 1, 2, and either feature 3 or 4 need to be present. So when the CAM is positive, patients have delirium. So we measured that daily for patients while they were in the ICU, and then followed up with them at 3 and 12 months after their critical illness. And the data I'm going to share with you here are from 1 year, and we're looking here at, on the x-axis, the days of delirium, and on the y-axis, the adjusted probability of a higher CATS-ADL score. And the CATS-ADL is a questionnaire-based tool to measure disability in activities of daily living, things like bathing, dressing, toileting, feeding yourself. And a higher score indicates new or worsened disability. And so in this study, after adjusting for traditional ICU risk factors, things like age and severity of illness, comorbidities, and the patient's baseline CATS-ADL score, we found that the longer patients were delirious, the greater probability that they would have a higher CATS-ADL score, indicating new or worse disability in activities of daily living. So delirium as an indicator of an underlying patient's vulnerability is associated with greater odds of disability among survivors of mechanical ventilation. The second syndrome that we looked at, we just had come out in the Blue Journal looking at a syndrome called frailty. And frailty is a syndrome that's characterized by the loss of physiologic reserve across multiple systems that reduces a patient's ability to restore and to maintain homeostasis. And that's a mouthful, but it's commonly described as a geriatric syndrome, and up to about a third of patients in the ICU will develop frailty during their illness. And there's multiple different ways to measure frailty. One way that's been well validated in the geriatrics literature, and now a Canadian group and our group have demonstrated validity of this tool, the clinical frailty scale, which is basically your clinical assessment of a patient, understanding their past medical history, their functional status, from looking at medical records, talking with families. And you rate people on this scale from 1, these are the very fit, these are the most healthy people in their age group, all the way up to, when we did this study, it was only went up to 7. Subsequently, they've added 8 and 9, but 7 is severely frail. These are people who are completely dependent on others for personal care, whether that's due to physical or cognitive problems. And a score of 5, 6, or 7, and 8 now indicate the clinical syndrome of frailty being present. And we looked at this in the context of an observational cohort study of over 1,000 patients, ranging from 18 years all the way up to over 65 years. And one of the first things I want to show you from this study is that we're looking at the clinical frailty scale score on the y-axis here, and we're stratifying it by age. So we have 30 and 40-year-olds, 50 and 60-year-olds, and those over the age of 65. Now, as I said earlier, frailty is considered generally to be a geriatric syndrome, so it would surprise no one that there's sort of a range of scores in this age group over the age of 65. Now let's look down at the 50 and 60-year-olds. Again, we see that similar range of people. Even in 30 and 40-year-olds of these people that are admitted to the ICU, there's a range of scores. And in fact, highlighted here in yellow are the patients who have the clinical syndrome of frailty. And in this cohort, over 50% of the patients who were frail were under the age of 65. So this demonstrates increased vulnerability even in these younger patients coming to us in the ICU. And when we followed these patients out to 1 year, we found a very nice dose-response curve, essentially, for the clinical frailty scale score presented here. You can see that those with a score of 1, the most fit patients, had the greatest survival, whereas those who were the most severely frail had the lowest score. Now, these are Kaplan-Meier curves, are always unadjusted, but when we went in and adjusted for those traditional things that we worry about in the ICU, how sick someone is, how many comorbidities they have, how old they are, what their baseline functional status is, the clinical frailty scale score also demonstrated that nice dose-response curve for mortality at 90 days and at a year. And when we looked at disability, we found that the clinical frailty scale score was associated with, and this time we're looking at IADLs, so a different set of disabilities, but IADLs, things like managing your finances, cooking a meal, being able to navigate transportation in your city. That the greater the clinical frailty scale score, the greater the probability of having new or worsened disability in those instrumental activities of daily living at 1 year. And when we looked at the effect of age on this, we did an interaction term, statistical interaction term looking at age. There was no difference. So even those younger patients who are frail are actually anywhere along this effect holds for those patients as well. So now I'd like to share with you some early work that we're doing looking at the role of acute inflammation in the development of delirium. We saw that delirium was associated with disability, and also looking at acute inflammation and subsequent disability. So to ask this question, we again looked at data from this 1,000-patient combined cohort study where we drew blood samples on study day 1, 3, and 5, and these patients were enrolled very early in their ICU course. We then measured concentrations of 11 markers: CRP, interferon, MMP9, IL-1, IL-6, 8, 10, 12, TNF-alpha, TNF receptor 1, and protein C. And we then looked at the value of these biomarkers on day 1 and then the mental status on the next day. So for day 1, it would be on day 2. For day 3, it's on day 4, and so on. And we also looked at the number of delirium coma-free days, which are the number of, everyone's heard of ventilator-free days, which is the number of days alive and off of the ventilator. Delirium coma-free days are days alive without delirium and coma. So number of days alive with good mental status, in other words. And these data are currently under review, so if anyone's taking pictures and tweeting, maybe that's my own ego getting in the way there. Please don't, so we can preserve this. But what we found was that there were, of those 11 biomarkers, there were 4 markers that were associated with mental status on the next day. And those markers were IL-6, IL-8, IL-10, and protein C. And there's a lot going on in this slide, so I'm going to take some time here and walk you through it. So what we have here on the x-axis are the natural log concentrations of each biomarker, okay? And we have three strata here. We have normal mental status, delirium, and coma. And then on the y-axis is the probability of having that mental status on the next day. So the probability of being normal, probability of having delirium, probability of having coma. And what you can see is that as the concentration of IL-6 increases, the probability of having a normal mental status goes down. And then the probability of having delirium or coma both increase. And both of those were statistically significant versus having normal mental status. Likewise, IL-8 showed a similar trend, increasing concentrations, lower probability of having normal mental status the next day, higher probability of having either delirium or having coma. IL-10, a similar trend there. And protein C showed a little bit different, but remember that protein C goes down in acute inflammation and critical illness. This is the rationale for giving activated protein C in severe sepsis, that levels go down. And so you see sort of the reverse, right? So lower concentrations associated with lower probability of having normal mental status, lower concentrations with higher probability of having delirium and coma. And when we followed those associations out over the next week, looking at those numbers of days alive and without delirium or coma, we saw a very similar trend. Again, IL-6, 8, 10, and protein C, statistically significant associations with, in this case, we're presenting the adjusted probability of having more delirium coma-free days, so more days of a good mental status, and you can see that more inflammation with lower days of having good mental status. Except for protein C, where, again, that similar reverse trend is present. So far I've shown you that delirium in the ICU is associated with a disability among survivors of critical illness, and shown you data that markers of inflammation and disordered hemostasis are associated with the development of delirium. And if we look at the literature in community-dwelling older adults where a lot of the disability work has been done, there's a number of studies, these are just a few, that show an association between chronic inflammation and the development of disability. So we asked the question whether these acute markers of inflammation that were associated with delirium would also predict the development of disability at 3 and 12 months after critical illness. So again, using that same cohort, that same 1,000-patient cohort, measuring markers on days 1, 3, and 5. And this time, instead of looking at delirium and coma, we're looking at ADLs and IADLs at 3 months and at 12 months. And what we found was that, let me present all this. What we found was a little bit interesting to me. But here we're looking at the individual markers and the association between marker concentration and a higher CAS-ADL score on this slide at 3 months and at 12 months. And we're comparing here in this study patients with marker levels at the 75th percentile to those with the 25th percentile. And statistically significant associations are shown in yellow. But if you'll notice something, if you're watching closely, you can see that there's a lot of yellow on there. but that they go on both sides of one. So some of these markers are showing associations, and others are showing associations with greater disability, and others are showing less disability, which doesn't make sense to us necessarily. So basically, I think this is a lot of sort of statistical noise in this finding. So we didn't see an association between concentrations of acute inflammation and disability at 3 or 12 months. Likewise with the IADLs, again, lots of statistically significant things, but we're all over the place in terms of direction of association. So we've talked today about the vulnerability hypothesis, that disability develops as a function of not only a patient's critical illness, but their underlying vulnerability, and that we can't really measure vulnerability in and of itself, but there are some things like delirium and frailty that are associated with disability that allow us to look a little bit closer at that vulnerability, and they're associated with bad outcomes after critical illness. And we've talked about acute inflammation being associated with the development of delirium and coma, but not with disability after critical illness. So I want to share with you now the study that we're undertaking called Mosaic, which is measuring outcomes of activity in intensive care. So we're looking at activity as a risk factor for disability. That's sort of the big push behind early mobility trials, yet we haven't really shown that in the long term activity is associated with this. So this is an observational trial, and we're measuring physical activity using the ICU mobility scale from here in Australia, as well as some accelerometers, and I'll show you a picture of those later. Things like, they're kind of like Fitbits is probably the thing that comes to mind, the most common way to think of an accelerometer. And looking at disability at 3 and 12 months. We're also measuring in detail, so the previous study that I showed you didn't have detailed physical functioning measures, things like muscle strength, gait speed, that sort of thing, and we're doing a good battery of cognitive testing as well to determine what the role of physical and cognitive function is in the development of disability. And we're also looking at the biomarkers of inflammation. So there's a number of studies out of the Pittsburgh group that show that even after we think as clinicians that you're clinically over your illness and you look well enough to go home, that if we drew biomarkers on you, we would see elevated markers of inflammation. And so it may be the case that those that go on to develop disability and cognitive impairment afterwards are those who don't resolve their inflammation by the time they leave the hospital. So we're testing that in the context of this observational study. And so here's a screenshot of a video. This is a woman who has a tracheostomy, and she's up walking, and we have patients wear these little accelerometers on their wrists and on their ankles that gives us an output called activity counts, which is a clinically meaningless thing, but it measures activity. It measures how much people are moving around. And this, for this woman, she's got 2 people helping her walk, and the x-axis here is time, and this is activity counts. And you can see that as she starts to move, the activity counts go up. She takes a little rest here, goes walking some more, takes a rest. So we're able to measure activity in reasonably granular detail in these patients. And the best part is they wear them all the time, so they measure it continuously. So that's all I have prepared for you. I want to plug our website just because it has good information from a clinical perspective and stuff about our ongoing research, that big team that I presented earlier, ranging from pediatrics all the way up to geriatrics. And I'm happy to answer any questions that you all have.